We're here with Peter O'Sullivan today. Hello, Peter. Thank you for joining us today.
Thank you.
We're going to have a chat to Peter about low back pain. But hopefully, first of all, Peter will be able to just talk to us a little bit about who he is and what he does and where he got to where he is today, or how he got to where he is today.
Okay, well, I'm originally grew up in New Zealand and studied in the south of New Zealand, did my my physiotherapy training there. Um, and after working for probably about 3 years, realised that I was kind of like a jack of all trades and a master of nothing. I had a whole lot of technical skills and I knew how to manipulate joints, and I'd been to a bunch of workshops, and I really felt quite confused around how to um, I felt confused and frustrated in the fact that I was really adopting a symptomatic approach of dealing with pain. So someone would come in, you try a technique, it would work or not. If it didn't work, you try something else, and it just seemed a very ad hoc, haphazard way of managing a problem. And I found it intensely frustrating. And I was also caught in a trap of treating people on a very rapid basis, and I was kind of hit a crisis point of thinking I can't do this anymore. And either I'm going to get out of this or I have to go and do further education. And at that point, I talked to a variety of people, and it was suggested to me that at that stage, many years ago, there were some good postgraduate programs running in Australia, and I elected to apply to Perth, which was at that point being run by Bob Elvey and other people like Lance Toomey and Brian Edwards and others who some of your listeners might have known about, who are real pioneers of physiotherapy when I was a young physio. So I went and did my postgraduate manipulative therapy training there. And I think that created a bit of a platform of understanding, or a clinical reasoning understanding of dealing with a problem, but it was still very unidimensional. And that was back in the days where everything was about the joint and the biomechanics. And then there was kind of emerging interest in the muscles. You know, we were getting away from joints and thinking about muscles. And when I finished that, I worked part time, half time with Bob Elvey in his practice, and also in a pain management clinic. And it was an incredibly interesting contrast. So in the pain management clinic, we had people coming in who started off having, you know, significant back pain, but after they've been pushed with all their injections and drugged, they often became completely disabled. And we saw at this one end of a spectrum in private practice of relatively well people who were bothered by a bit of pain coming in, and completely disabled people who were totally non-responsive to the kinds of, you know, mechanical therapies or the passive therapies that we applied. And it made me realize that there was this whole spectrum of pain that my training just was not well equipped to dealing with. And also there was almost no evidence to support that what physiotherapy did made any difference with these people. So that's why I embarked on my PhD research, again, many years back. And back in those days, my perspective again was very much biomechanics and structural, which was very much linked to my training at that stage. So I kind of attacked my PhD from that perspective, and I kind of got caught up in the wave of, you know, looking at this idea that spines, you know, if you couldn't find a structural problem, it's because there was some underlying instability, and you had to, you know, target stabilizing muscles to train them up, and that was going to be the panacea. And of course, in that process, it's a pretty painful process doing research, because you manage to, you know, you set up hypotheses, you test them, and you realize that pretty much all the things you thought that were true weren't true. And so it forces you to reflect back on what your beliefs were, and then a painful process of change. And really, since that time, since that time of finishing my PhD, I've worked part-time in practice, where I work half-time and half-time in research, predominantly doing clinical research and a small amount of postgraduate teaching. And it's a really lovely integration of um, I think asking difficult questions and testing them in a lab situation and then going back to the clinic and with every patient, in a sense, is like a case study of hypothesis testing. And and across that journey, I've been linked, very fortunate to be linked with a whole lot of wonderful researchers who have really forced me to change my perspectives around looking at pain and realizing that pain is a complex, multi-dimensional experience that is very rarely about structure. It is very often about the person's experience and processes that involve sensitizing structures and emotional responses and the beliefs that drive behaviors that will confront us in clinical practice. And so that's kind of forced me to develop a whole different way of looking at pain and broaden my scope of practice to understand that we need a broader skill set to deal with it more effectively. So that's sort of, capsulizes my journey, I suppose, of really a tandem journey of both clinical research and clinical practice, and the merging of both, which is really where I'm passionately interested in trying to upskill, I think, our profession to be a more effective at dealing with tough pain disorders. Because I think we know as a society, we've done very badly with treating pain. We're good at doing symptomatic stuff, but we're not very able to change the long-term trajectories of these disorders.
So it's an interesting story. So do you practice clinically now still? Is that correct?
Yep,
Yeah. And
yep.
it's very pain focused, and do you specialize in low back pain, or do you
Um,
see all kinds
well,
of patients?
no, I treat anything that comes in the door. So the all the patients I would see would have persistent pain disorders. It's of musculoskeletal origin. Um, in our research, we have tended to focus on the back because the back is such a big problem, and it's a really good model to test understanding pain. We're now merging into other areas in terms of looking at neck pain, shoulder pain, hip and knee pain, because we see the same factors that are important for backs are really no different to other body parts. And the systems that we're developing for managing or considering and managing the back seems to have good parallel for other pain disorders as well. So in clinical practice, I see anything, and that's cool. I mean, I get anything from a regional pain disorder of the arm to chronic headaches to shoulder problems to knee and foot pain, or I had a lady yesterday with anteromedial hip pain who had been to the surgeon, told she had a labral tear, stuck with an injection, now is quite disabled and doesn't know what to do with herself. So they're the kinds of people who I go through trying to unravel the complexity of their problem and then set them with a pathway to control their pain and develop independence.
So I think it's really interesting. I think it's that's really good that you still see patients with all different conditions to be able to apply your knowledge and all that you found out to them and investigate more. And I imagine you find that really, really useful to apply things that
So,
you're thinking about.
well, it's like test driving a car. I think you can't develop something in a lab and not test drive it. And the patients, I kind of reflect on the fact that my patients have been honest enough to come back to tell me that what I've done hasn't worked. And that's been one of the most powerful learning strategies for me for them having the trust to tell me where I've gone wrong in a sense. And I think in clinical practice, we can get very blind to think that what we're doing works for everyone. And all we're seeing is our successes returning, and that self-confirmatory kind of process can be very misleading. Um, where I've been very fortunate to have people come back and go, this is not working for me, but I bothered to come back to tell you because I think that they realize I'm interested in the journey and genuinely interested to see if we can help people in that process. So um, yeah, it's that's where I develop all my research ideas is from practice essentially.
I mean, as a profession, we're not going to learn unless we hear from the people that we're not helping as well, are we?
Exactly. Yeah, and we just recently, I've had two of our PhDs have been involved in qualitative research, and to me, it's almost like coming back to the clinic where you actually get detailed knowledge of the person's story, and that whole idea of understanding pain through the lens of the individual who suffers from it, which takes away from this, I'm the expert clinician and I'll tell you how it is, to actually getting inside the head of the person who's suffering and saying, what's it like to be in that body? How does it feel? How does it feel that you, like I had a 72-year-old who'd not bent over, in 20 or 40 years. And, he bent over for the first time and burst into tears, going, I never believed I could do this. I've lived with this problem and believing that I had this damaged spine and have been so frightened. And every time I go to bend, I panic. And so I don't bend and I tense up. And you just see how these extraordinary processes where fear and behavioral responses to fear and pain get people trapped in a cycle of pain and disability.
So you've just totally described how amazing our profession can be in helping these people, how amazing physiotherapy is. But just, yeah, just can you just tell us a little bit about the story of your research? What did you start with researching and where are you now and what's your team looking into now?
Yep. So probably reflects my clinical journey in a sense, and that right at the beginning, we were really looking at, I suppose I've always been very interested in what I would have called, the movement related behaviors associated with pain, but I interpreted them as biomechanics back then, where now I would look at movement as just an expression of a person. It's a behavior. So how you hold yourself, how you move, um, your strategy of bending down to pick up a shoe or lifting a box reflects your beliefs, your fear, your confidence, your levels of self-efficacy, um, uh, a whole lot of factors. And so we were looking at things like movement and motor control strategies around movement for people with pain. And then that's really broadened hugely to say, to realizing that movement is just one part of a complex jigsaw puzzle, and that all of the studies that we're involved in now are considering the multiple dimensions of pain. So that means that for any pain disorder or anyone who comes in through the door, you've got to go first through a triage system where you make sure it's not bad stuff. You're not treating a malignancy or a fracture or an infection.
So the red flags.
Yeah, and then it gets more complicated because what we've got now is a situation where so many of our patients are getting scanned, and um, the MRI scanning is so sensitive; it's picking up stuff in everybody. So if you look at the number of people without back pain who have so-called abnormalities, they're so prevalent that everyone's getting diagnosed with a degenerate disc or a disc bulge now. And so what we've taken from a group of people who've got so-called non-specific back pain, we've kind of now given them a pathoanatomical diagnosis, which we know frightens the hell out of people and has a negative impact on their health outcomes and a whole bunch of their behavior. So within that model, we consider factors like pathoanatomy, but also a person's the nature of their pain. So we know that pain for some people can be constant, non-remitting, and not provoked by movement. For others, it's clearly linked to specific movements, and it could be a direction of movement. And we know that for some people, they do a minor event and get this massive pain response. And this is influenced by neurophysiological processes, which could influence things like central sensitization. So we're within our studies now, we're measuring sensory profiles like cold and pressure hyperalgesia and pain responses to movement. And those are really revealing. And they interact with other things like your psychosocial profile. So, someone's highly distressed, not sleeping, not active, suffers from depression and is highly fearful, that will influence their pain responses to movement, the way they move, as well as their sensory profile in relation to movement. So within all our research, we kind of look at it from these dimensions of saying, what's your sensory profile? What's your psychosocial profile? What are your behaviors in terms of the way you go about your movement? And how does that influence your life? And what's your coping strategies? For some people, they cope by ignoring pain and just flogging themselves. For others, they're too frightened to move, so they start becoming very avoidant. Um, and so it's this wonderful complexity that differs for every person. And I think the great challenge for us as researchers and as clinicians is to develop what we think is to develop a framework that's logical, sensible, and applicable that allows a clinician to confidently consider the different dimensions that need to be considered in pain, and then can set about working out which of those factors are modifiable and targeting care in a different way. And so our idea of management is moving way away from probably historical approaches of managing pain, which is very much around passive therapies. So we know that, passive treatments like mobilization, manipulation, soft tissue work, needling, etc., is very much about short-term modulation of pain, but it's very unlikely to influence pain in the long term. And it doesn't provide people with strategies of self-management. And we know that particularly with chronic health disorders, that self-management is really important. So empowering the individual to develop strategies to manage their disorder on their own is really important in terms of giving them the tools to self-manage. So our interventions are really around targeting those factors that are relevant for the person. And that's where we've coined this idea of a cognitive functional approach, because we know that these pain disorders are linked to often negative beliefs, fear, catastrophic thoughts, high levels of distress and low levels of self-efficacy, but they also reflected in the way that people move. So developing highly guarded and protective patterns of movement are very common with people with pain, particularly if they're distressed. And those behaviors in themselves become highly provocative. So they start overprotecting painful structures because they're frightened, and in doing that, provoke the very thing that frightens them. And so we kind of see they get caught in this trap. And we go about unraveling that process for them and, giving them building blocks to kind of get out of trouble.
And so, from what I understand, those building blocks, I kind of understand them to be sort of three aspects. There's the
Right.
cognitive behavioral
Yeah.
aspect where you're targeting their beliefs and behaviors, the functional
Yeah.
behavioral aspect where you're looking at their movement patterns, and then the lifestyle
Yeah.
aspect where you're
Yeah.
changing their lifestyle adaptations that they've made.
Yeah.
Is that correct?
Yeah. Definitely. And even though we kind of separate them, they're intimately connected. So and one of the things I think that's quite unique to this process is trying to give people control over their pain. So what we observe is that a lot of people with back pain actually adopt behaviors which are really provocative, and we can quite quickly break them down and give them new strategies to move that actually are not painful. So it's not like you just got to tell people, look, you're safe to bend even though they hurt. You can actually give them a different strategy which often breaks their behaviors and gets them to do the thing that they thought they couldn't do and actually isn't as painful. So there are a lot of the cognitive stuff is done through what we call behavior experiments. And an example of a behavioral experiment might be this chap I mentioned earlier, who's frightened to bend over. He won't bend over. And when he goes to bend, he keeps his back in hyperlordosis and he braces his stomach and he props his hand on his leg. And so we would go through a process of saying, well, okay, so you've got nothing on your scan. What do you think is going to happen if you did bend? Well, I think I'm going to, end up doing damage. Well, what do you think you might be damaging? Well, I don't know, but there's something in there. I can feel it's terrible. And so you poke on his back and it's highly sensitive, very highly sensitized. He's totally co-contracted. So then we go through a process of going, well, okay, let's just have a look at that. And we lie him down and get him to relax and breathe and then flex his legs and get him to sitting. And before you know it, we actually start inducing him to flex and relax his back, and then take him through a graduated process to bend over and touch his toes, and it doesn't hurt him. Now, by taking him through that process confidently, tells him bending safe. But I couldn't have told him it. I could only show him that process. Does that make sense? So we use these, what we call behavioral experiments, where we take people back into threatened activities that freak them out, break them down and take them back in a graduated way, breaking down their fear responses, because I had him lying down, and even to imagine bending made him brace his back, just to imagine it. So we know that, these pain memories are so powerful, they will generate behaviors. So he started to realize just the thought of movement made him tense. And he actually experienced pain just thinking about it. So that's not just about the back, it's about the beliefs and the encoding of pain in the central nervous system, or whatever's happening in that process, and the threat that creates these behaviors that maintain pain, and then you're caught in a loop. And so because of that, this guy's not exercising. He stopped playing golf. He's not gardening. He's spending too much time sitting around. He's now got high blood pressure. He's put on weight. He's quite down and feels like, his life's coming to an end. He can't do the things that are important in his life. So it impacts on all these health comorbidities and his lifestyle factors. So by giving him a pain control strategy, we can then address his beliefs, take him back to the things he thought he couldn't do, get him back doing the things he wants to do in life, the things that give him value, find a way of getting him back to play golf. That, in a sense, has an impact on all those health comorbidities like his weight and his blood pressure and his general health and mood. And there you've made a change.
Yeah, absolutely. And so that's you call that intervention a behavioral experiment.
Well, it's a series of behavioral experiments um, that really forced the individual to question their own beliefs in their own body through experiencing something completely contradictory to what they thought.
And I
If that
suppose
makes sense.
yeah, absolutely. And you target probably, so you're targeting the movement patterns that they maladapted movement patterns.
The things they most fear and avoid are what we target.
Brilliant.
So we're not interested in lying people down on beds unless lying down's a problem, or unless they're so frightened you've got to start in a non-threatening way, which might be lying down.
Yeah. So you target the
So
thing where you say, what's the
yeah.
thing that you're most concerned about?
Yeah.
Yeah.
So typically I'd say, so what provokes your pain? You go, well, it's worse when I'm, bending, lifting. And what are the things that you avoid? How have you modified your life? He's going, well, I don't play golf anymore. Why is that? Well, every time I twist, I hurt my back and I can't bend down and pick the golf ball up. So that would trigger me to look at what he does to pick up a golf ball and what position he'd be in and what he does when he rotates his body. And so what you realize, the guy is massively co-contracted. So he's frightened to twist and to bend. So they become the targets.
And so I guess all the time that you're doing this behavioural experiment, you're also trying to target their maladapted beliefs and behaviours through communication.
Absolutely. So you're reflecting back. So, me getting him to lie down and imagine bending and him feeling that he held his breath and tensed his back muscles, because I've got my hand on his belly and on his back. We can monitor that. It's like a feedback. It's like a biofeedback. And then you can say to him, so what is that telling you about the thought of bending? And he would say, well, it's telling me that even the thought of bending makes me tense. And so how would it be that every time you tensed your wrist and went to bend it, how would that feel for you? Well, that would be painful. So do you think you might be doing that for your back? So we use a lot of reflective questioning. So it's quite a non-judgmental approach of reflective questioning, of asking the person to really dig deep into their thoughts around their behaviors. And it's actually a very revealing process. And one of the things that someone has mentioned to me recently is if you work hard on your patient in an examination, you've done something wrong.
Right, yeah.
Like, it's a process for them. It's a really hard work process for them because they're being made to self-reflect.
And this is about, this is moving into helping patients or individuals with pain to take responsibility for their own healthcare, isn't it, as well?
Absolutely. Look, I get a lot of flack about this because, people think because I used to be, well, because I'm a manipulative therapist, I've gone to some kind of dark practice. But I think, to provide someone with the tools to care for themselves is so much more rewarding than to create a quick fix that then they become dependent on you on. And I look back and shudder at some of the ways I used to work where as a manual therapist, you can provide pain relief quite effectively. But for people who are really disabled, it just leaves them trapped in a very dependent cycle where they feel like they're not empowered to be in control of their problem. Now, that's not to say that there's no role in manual therapy, because I think where the person is really fearful, you can use manual therapy as a means of providing a window of opportunity to build confidence that movement is safe. But I think in its own, it's such a limited tool.
So you're talking about kind of classifying. Do you classify patients into this approach?
What we have developed, and we're writing a paper at the moment that's doing the rounds, is we kind of describe it as a framework more than it's not really a subgrouping system. So it's really to say, look, every person who walks in your door, you've got to consider triage. You've got to consider whether there are pathoanatomical factors. Consider their sensory profile. What's the nature of their pain? What are the things that provoke it? What are the things that they fear and avoid? Consider their levels of distress. Consider the things that their level of fear, and consider their beliefs. Then when you examine them, consider the strategies they use to move. And within our work, we've identified that you can characterize movement into sort of broad strategies. Everyone's unique, but there are kind of commonalities in terms of the way that people can present. And then we consider what other factors are happening in your life in terms of your social setting, because they could be really important. Like what's happening at home or at work could be a major factor. I saw a lady yesterday had a pain flare up. She just put her mum in a nursing home, and her mum's suffering from dementia, and she's highly stressed, and she's not been sleeping, and she's not been exercising, and she's had a massive flare up. Now her social context is so important to understanding her pain. She's had no event. There's no injury. She's had a pain flare because she's got all these contextual stresses and lifestyle factors that are interplaying with the pain. Now, for me, that's really important as a clinician to go, yeah, I get it. Your system's sensitized because you're run down and highly distressed. And my job is to reassure her that she's not damaged, that this is just a normal phenomena because she's really overcooking herself. So within that framework, we consider all the dimensions and then go, what are the things within those dimensions that we can change? So there are some things you can't change. You can't change the fact your mum's gone into a nursing home, but you can change the way you respond to it. And what we often see when people get in pain is they panic, they get worried, they start protecting, they stop exercising, they don't sleep as well, they might start drinking more alcohol, whatever. And we would try and send them down a different pathway to say, when you're most vulnerable, you've got to be most careful with your health. So you build resilience into your system, that you keep up with your physical activity, you protect your sleep, that will give you strategies to relax when you're tense, that if you feel pain, you don't panic, you realize what you're dealing with. It's not damaged. This is a sensitized system. And often when you give people those tools, they think differently about pain. They don't panic. They realize they have a different mindset to deal with it. And I think that's really empowering.
I was just thinking. I really like this approach of empowering patients and teaching them how to take responsibility for their own health care.
Yeah.
And
Yeah.
and it seems to me, like this approach is, as I listen to you, and I know this sort of approach has been talked about as being appropriate for more chronic conditions, more chronic pain conditions, but I can just see how it's appropriate for how you can sort of apply it to an acute stage as well, because you can apply it to the acute stage and use these techniques to prevent it becoming into this chronic state where you get this man that can't bend or hasn't bent for 20 years.
Yeah. And I think that the whole issue around acute pain is we often presume acute pain is like an injury, but for a lot of people it's just an acute period of stress, or you know it's just a crisis in their life. It may not be they've done anything. And if you a lot of the people we see coming in who are acutely distressed with pain, and even if you talk to people in emergency settings in hospital, they'll say it was a minor event, and it will not, usually it won't be the damage to the structure. It'll be some crisis that's happened for the person that set them up. And I think understanding that people's distress doesn't correlate well with their pathology. It correlates well with other stuff. And that's really important for us because I think as physiotherapists, we often we kind of buy into people's distress and we start worrying about it and think there's something dangerous happening. And we've been so pathologized in terms of thinking that bending's dangerous and somehow we're going to prolapse our disc when you bend over. Where actual fact, bending's a wonderful thing to do. It's very relaxing. It helps you relax your muscles. You know, it's so I think approaching pain in this way does take a bit of unlearning for a lot of people because we've been so steeped in thinking pain equals damage. Pain means you shouldn't do it. Let pain guide how much you move, etc., which have really have got us into a lot of trouble, I think, as a profession and as a society.
Yeah. So two things cross my mind, and I'm totally imagining that you still see a place for manual therapy and hands-on
Absolutely.
techniques, and that this just is a complement to that in the
Yeah.
so particularly in the acute and subacute and earlier stages of injury or illness or
Yeah. So again, my view on manual therapy, if there's a clear barrier to movement, if someone's got a limitation of movement, then manual therapy can be an adjunct to provide both pain relief and to facilitate movement to tell the person that movement's good. Like relaxed movement is good and healthy, and manual therapy's got a role in doing that. But I believe it must be coupled with behavioural change. It's not it's not enough just to do it, but you've got to couple it with good education. So you can tell somebody if they've got a painfully restricted region of their back, you can tell them that what I'm doing is I'm just giving you a strategy to move, and this is the reason you're feeling better is because movement is good, and we're going to couple that with teaching you how to do this yourself, and then we've got to get you to go back to doing the things that you think you can't do to realize that you can maintain this.
yeah.
Because what happens otherwise, you get this bounce back where the person goes, "Well, I had manipulation. It lasted 3 days, and I'm coming back, and I become dependent on it." And those passive therapies are very unhelpful in the long run if they're not combined. Now, there is a group of people who become heavily dependent on them, and the other group you really want to get away from that. I'll give you an example. I saw a lady yesterday who's a very interesting case. She presented with, she reported back pain, bilateral knee pain. She'd had two arthroscopes and restless leg syndrome. And she was highly distressed and not sleeping and was too frightened to travel because she got this restless legs. And so it really affected her life. And this whole thing had started around a time in her life when her husband had died and she had to move house. It was very stressful. And she reported now that she'd become very fearful of this back and her leg pain. And she stopped using, she'd been protecting her knees because she'd been told one day she needed a knee replacement. So her balance was affected and she stopped exercising. So you've straight away got a whole bunch of different pain comorbidities. You've got someone who's frightened and anxious, where pain developed in a stressful period of their life. Now, she sat bolt upright, guarded, tense, fidgeted, couldn't relax. She was almost in a state of hyperventilation. And I went through this process just reflecting on what I was seeing and then getting her to relax her body. And then I realized, got to reflect on her breathing pattern. The fact she couldn't slow her breathing rate down. It was erratic and upper chest breathing. Got her to lie down. I got her to slow her breathing down. Got her to relax her postures. Got her then to back into sitting and to just feel her body relax. And I had a colleague sitting with me and he said, I could have palpated her back and identified stiff joints and painful structures, and I could have mobilized them, but it wouldn't have taught her that actually what's driving this process is her anxiety and fear and stress around the pain. Now, she to me is a great example of where manual therapy would have been a roadblock for her to learn that she could control her pain because there was no really major impairments of movements. I could have found tender points and stiffness, which I could have treated, but I don't think it would have allowed me to give her, when she walked out the door, this belief that she had control over that problem, that she could have mastery over it. And that's where I deliberately elect not to do manual therapy.
Yeah, for sure. And that's an example of a chronic case again. But and I guess in so and it's a really good example and it's really interesting and it's totally enlightening to hear you give an example. The examples are great that you're giving. And I imagine, but in the acute scenario, it's completely different, isn't it? Because you wouldn't have that person that's, well, maybe you would, that's
Yes
bracing
and
and
no. Yes and no. I mean,
yeah,
look, you'll get someone who comes in to see you, and look, when we talk acute, I know Jonathan Hill talks about back pain is a bit like asthma, where you have this grumbling pain and acute flare. Is it really acute? I mean, we know from our trajectory, we're involved in epidemiological studies that have looked at the tracking of pain from adolescence into adulthood. And we know there's a group of about 30% of adolescents who report back and neck pain at the age of 14. Those people track right through. There's a group of them that track right through into age of 23. And those people are getting episodes of back pain that have been tracking since they're 14. That group of people, if you look at their early life trajectory, even at the age of 2, 5, 7, and 10, some of them are predicted by showing signs of lower mood or heightened anxiety. So when we're talking about acute pain, often what we're talking about is an acute flare of an underlying disorder. And that acute flare could be an acute sensitization of structures that may be linked to muscle guarding, and it could be around a crisis in terms of lifestyle factors or some kind of emotional event that triggers a pain response. And the way I would manage that would be to say, what are the factors that you're dealing with? What are your behaviors as you present? What is a strategy? What strategies can I use to give you control over this problem and to deliver an intervention that makes you feel confident that you can get on with your life? And then look at developing a strategy to prevent recurrence. Now that may involve manual therapy for some, but it may not for others.
and I guess, and so I'm thinking about it as well now. Even if we think about the context of a sprained ankle, which
Yeah,
is more on the
exactly.
pathoanatomical side, but we would still go in there and say, don't be afraid to move it, wouldn't we?
Yeah, but where the problem comes with back pain is that there's a large group of people who can't tell you a clear event. Like you've had a sprained ankle, right?
Yep.
Because you're running along and you put your foot in a hole. I've had sprained ankles before. There is no doubt I have sprained my ankle and I
Yeah.
can't run on it, right?
Yeah.
That's different than the person who wakes up and they can't move. That's different than the person who rolls over in bed and locks up. Is that you're going to do to yourself damage rolling over in bed? You know, there was an interview with a chap I did on our national radio I think it was last year or year before, and he described how he woke up, he slept on the floor at the school camp, hurt his back seized up. It's hardly an injury.
Yeah.
So what we often do is I think we think of pain as injury, and I think it's a huge mistake. Now that's different than someone who said, "Look, uh, I was lifting a really heavy box and I slipped and I fell and I went to grab it." Or you might give an example of a nurse who's dropped a really 120 kilogram patient. To me, that's an injury.
Yeah.
That's how I would treat that injury like a sprained ankle, where you'd say, look, there's an acute inflammatory process. We're going to settle it down. We tape you up. We let it calm down. Then we get you moving.
Yeah.
But a lot of the people who present with back pain do not present like that.
Yeah.
But we presume
Interesting.
they do.
Yeah, no,
We
it's really
presume
interesting.
they do.
Yeah, and it's good. It's interesting, and it's really good to hear you also say how you would approach that acute sprain of the nurse that dropped the patient and things
Exactly.
in the same way.
Yeah.
That's really good. And
And look, that's no different than someone who's got acute radiculopathy. If someone's got acute radiculopathy, you're not going to push them around too much. You've got to let that acute inflammatory process settle. And part of that's understanding pain mechanisms that, when your person comes in, we know there are different mechanisms. You can have a nociceptive pain that's linked to an inflammatory process. That's different than what would we call functional pain, where you've got a sensitized system for all the other factors that we know are commonly linked to back pain. They need to be managed differently, I reckon.
yeah, for sure, definitely. So Um, so this approach it's obviously really important that we all, as physiotherapists, know about this approach and integrate it into the management of our patients. So, and it is a shift from our historical model of patient care. So, how for people that don't have any insight into this kind of approach, how would you suggest that because it's quite a lot to take in all at once, so how would you
It
suggest that
is.
people just enter into using this approach, or what should they read? What should they start with using?
So, with my colleagues Kieran O'Sullivan and Wim Dankitz and Sharton Fursum, Kieran got a grant from the European Union to set up a website called Pain Ed, and we've deliberately kept that website open access, so it's all free, open, and we've got two aspects of that website. One is patient stories, which
Nice.
is we're capturing the stories of people who've been really disabled with pain, and they tell their own story from their perspective, which I think is really powerful. And it's really helpful both for physios as well as for patients to hear those stories. And we get people coming to see us now because they've come across the stories and they've gone, there's something about that story that makes me think of that's like me. And that's a journey I want to go through. So that's one aspect of that. The other aspect is we post research articles that we think will help clinicians on that journey to kind of develop skills. And that's our vehicle of trying to translate what we're doing into practice. Um, there are also workshops that are run in different parts of the world, which are very practical. We bring in people with, who are experiencing disabling pain, because we don't see this as a technique. We see this as a clinical reasoning approach of upskilling people
And I think that's why
around
it's
around
difficult. Yeah.
around their communication skills,
Yeah.
their thinking skills, their analytical skills, their training skills, and that's why, in a sense, there are different kind of skill sets that are required. Some physios pick it up really quickly and just run with it. For others, it takes more time. Um, we've got one of Ian Cowart, based in the UK, is doing his PhD, looking at taking a group of physios and looking at seeing what it takes to upskill people across these dimensions and whether they can agree on them, because that's important as well. We're trying to work out the best ways of teaching, and we think a mixed approach of both written, looking at case studies, and that's why I mentioned earlier we've posted the stories of people on YouTube, of patients who have tell their story and go through an intervention and tell their after story, because again we think they're quite helpful for people to build. I think a lot of it's just building the therapist's confidence as well, to deal with pain. We're frightened. I think generally we fear pain, and backs for some reason are more feared than other bits of the body, which is crazy. But that's that's the side of and it's got worse with the adjunct of MRI scanning.
Yeah, for sure, definitely.
So the PainEd website is what we're using to try and help that. We've published bucket loads of papers, and the ones that are open access we have got up on that website.
Okay.
Uh,
That's great.
uh,
I think that's really
and that,
useful because so for people that are unable to attend your um,
absolutely.
courses or teachings,
Yeah,
then I think the Pain Ed, it's pain-ed.com, and we'll
that's
make
right.
some link. We'll make some links available to this.
Mm.
I think for people that can't access your teachings, then that's going to be a really nice place for them to
Yeah,
learn more
and,
about this
and
approach.
yeah, the other thing that we're doing is we realise social media is probably quite important. Is through the Twitter sphere, and I actually I've been a bit of a late comer to social media, but I actually realise it's actually very important. And one of the things that we can use Twitter as a way of feeding new posts through the website. So
What's your
so
Twitter handle?
uh, Pete O'Sullivan PT.
Okay.
That's my Twitter address. And again, that's a way in which we can look at other people's work and go, I value that work. That's something that I support. Um, uh, so that's the other area we try and use for dissemination.
So you're going to get lots of people tweeting you now with all their questions, you realise?
Look, the great thing about Twitter is you can only be brief. It's wonderful.
Yeah.
So you can, and you can make a quick, brief statement, but you can also, just highlight to people that there are other resources that are available. I think the other thing to just highlight here, this is not the end point in a destination. This is part of a journey, and so part of our and the other point to make here is I'm linked to a number of researchers who share that journey with me. So I'm only one part of a kind of jigsaw puzzle.
Just tell us who the other research. Just remind us who the other researchers are again, who you work with.
So at Curtin University, where I'm based, Anne Smith is a biostatistician and physiotherapist who's incredibly clever lady who I work very closely with. Leon Straker is also a professor at the university who I work closely with. Helen Slater, Darren Beals, also other researchers who I'm linked to internationally. Kieran O'Sullivan in Limerick University, really clever chap who's they're running a randomised controlled trial testing this approach at the moment. Mary O'Keefe is involved with that. Wim Dankert's based in Belgium, did his PhD with me a number of years ago, and he's involved with a number of studies. Shanton Fursum is in Norway, and he did the RCT, testing this approach in a chronic back pain population, and he's involved with the second trial at the moment. That's just to name a few of our people who we're working with. The great thing about the world at the moment is the ability to kind of, with this kind of media, is to link with people in different parts of the world. And I'm sure I've forgotten some people I should have mentioned.
Well,
yeah, I've got there are a number. But,
yeah, I think it's useful just for people to know, for the names to look out for in association with this.
Yeah, and it's really important for me to acknowledge those people, because I'm only part of that process as well.
Absolutely, all research teams and things are huge.
Absolutely.
So we thank everyone. Yeah, we thank everyone for working on this. But so I think that's probably respectful of your time, and that's a nice place to end. But is there anything else that you'd like to add to this conversation just before we end?
Not really. We're just to say that the model we're kind of proposing for clinicians to deal with back pain, we're looking at applying it in other areas I mentioned, and that's an area we're quite interested in because we see the same factors popping up with OA knee. People are frightened of their knees; they think they've got to protect it. They develop abnormal behaviours and avoidance, and it's the very thing that's not good for knees. So same thing. I think we're pathologizing so many body parts now with the advent of ultrasound and MRI scanning. Every second person's got a labral tear, and so we're pathologizing hip pain. The likes of Jeremy Lewis, I think is doing a great story with the shoulder in terms of what's the relevance of what you see in a scan for the shoulder. And so these models we see applied at different parts of the neck as well. And that's where we see ourselves going in the future, is to broaden this model across other areas. But also we love people's feedback. So the things they've find confusing or difficult in the work that we promote, we're very reactive and responsive to people telling us if they think it doesn't make sense or it's too difficult. Because our real endeavour is to try and shift practice to empower people to deal with pain better. That's what we're interested in doing.
Well, and I think this conversation has been a really good contribution to that. Definitely, everyone will be able to have a listen to this. I've certainly learned a lot. It's been really, really interesting and a pleasure to talk to you. So thank you very much for your time today.
That's a pleasure. Thank you. All the best. Bye.